Here we go. So first of all, we're going to talk about the project. So we have a project, CHAMPS is a breastfeeding-focused initiative which is supposed to improve maternal-child health outcomes and exclusive breastfeeding. That is our bigger goal, to work to improve maternal-child health outcomes and exclusive breastfeeding. And our funders is the Kellogg Foundation, and they have asked us to specifically focus on 3 areas for now: Mississippi, New Orleans, and Southern Texas. The start date for the project was August 1, so we're only just getting everything organized and together. We have a group of people I'm going to introduce to you. And as I say, it's a 3-year project, and the Kellogg Foundation is funding it. So before we get started, those of us who are sort of all over the country, we're going to have you hear from some of the people who are right there in Mississippi just for a couple of minutes. We have Dr. Collier on the phone, and we have Tony Hill on the phone. And Dr. Collier, if you could just introduce yourself and tell us in a couple of minutes why it's important to do this kind of breastfeeding hospital community work in Mississippi right now.
Great. Thank you so much. Can you hear me okay?
Yeah.
Great. So my name is Dr. Great. My name is Dr. Charlene Collier. I am an OBGYN and a child health epidemiologist. I work State Department of Health in Mississippi as a perinatal health consultant. And what we specifically on help improve outcomes in Mississippi, particularly infant mortality, preterm birth, and outcomes. And breastfeeding is at the cornerstone of this important initiative. We know we have the highest preterm birth rate in the country. We have among the highest infant mortality rates. And we have the lowest rates of breast in the country, as well as no baby-friendly hospitals yet in the state, although we're going to get there. And we understand that increasing breast will have a significant public health impact in the state of Mississippi, both improving our outcomes for our very sick babies that we are seeing born in the state, very premature and low birth weight. We know that increasing breast help them as well as all of our infants in terms of reducing any childhood illness, as well as the chronic health diseases that we're seeing plague the state and benefits that we're missing out on for mothers, as well as weight loss and long-term health effects of breast cancer. It's a significant public health as well as an economic impact on the state by our load. We know there's things out there, there are changes out there that really improve our status. And
excuse me, just a second, Dr. Collier. For everyone else on the phone, if you're not speaking, could you please place your phone on mute, because there's a lot of interference and I can see people's names coming up as it's just like background noise. Just please put your own phone on mute so that we can hear Dr. Collier a little better. Thank you, Dr. Collier. Sorry.
So ultimately, I think the best way we can make improvements across the state is collaboratively so that we can see these changes in a rapid cycle, that we don't have to wait for many, many years to see changes. I think if we work together as a state with addressing both the community and cultural issues that are barriers to effective breastfeeding, as well as the hospital-based barriers that exist, we can see some dramatic changes that I think will have a tremendous and far-reaching impact on the overall health of the state of Mississippi and not just maternal or infant health. So thank you, and I'm looking forward to the presentation today.
Thank you, and thank you for your introduction. Tony, would you like to speak up? We had, I know that you're working in the community in Mississippi as a doula, so would you like to give us a few words as to, from your perspective and from the community perspective, why this is very important?
Yes, I think it's really important for everybody to pretty much be on the same page. I think what happens a lot within the community is the right hand doesn't really know what the left hand is doing, basically. Even from a nonprofit standpoint, a lot of times other nonprofits don't know what other nonprofits are doing, and we're kind of reinventing the wheel a little bit. And what ends up being the problem is that the mothers and the families are not getting the support that they need in a timely manner. You know, even so much as connecting hospitals with, you know, continuity of care, of making sure that WIC knows about their WIC mothers have delivered, or even as much as making sure that a mom who may not have as much support knows, about Little H League or the Birthing Project or an independent IBCLC, someone outside of the hospital spectrum, just so she can get the help that she needs in a timely manner. Because I think that's what really ends up being a problem for the moms, is that mothers will initiate breastfeeding, as you see with our numbers. I mean, we went up by about 9 points on our initiation rate in Mississippi, but when you see where it goes at 3 months, you see that it's dropped down significantly, still within a low range. And so obviously mothers are thinking about breastfeeding. They're actually, trying to give that a start, but they're not having the, they're not continuing. So I think that's the, the really important fact, really important thing about us all connecting and, being able to be and to be able to give, more support for the mothers as well as the families, around breastfeeding, so everybody knows what everybody's doing, and so that the mothers can be best supported.
Thank you. That's actually exactly what we hope to do, to link all the different groups together, both through like the Kellogg grantee network and the hospitals and the prenatal clinics. Sometimes the hospital tells they can't reach the prenatal clinics and vice versa, and then with WIC and the community. So that's a perfect introduction, Tony, and thank you very much. It's great to have you on the call. Tiffany, would you like to speak up a little bit? Tiffany is from the Department of Health at Mississippi, and she's going to tell us a little bit about some of the background in the Mississippi State Department and what they have done so far with breastfeeding and what some of their goals are and how they're going to help work with us. And I'll advance your slides, Tiffany, so just let me know.
Okay, thank you. Good afternoon, everyone. I am Tiffany Grant with the Office of Preventive Health, the Mississippi State Department of Health. Mississippi State Department of Health received funding just recently to initiate and work on baby-friendly hospitals in the state of Mississippi. So we have contracted with the Mississippi Public Health Institute to assist us in doing some of the following things: to increase access to breastfeeding-friendly environments through assessing breastfeeding policies, laws, and accommodations for hospitals. We're also going to work to educate and engage key hospital decision makers. And then we would like to establish baby-friendly hospital initiative guidelines and evaluation criteria for statewide initiatives. And next we will report quality measures related to breastfeeding, create a learning collaborative for quality improvement, and then also provide technical assistance to hospitals as they move forward with their breastfeeding initiatives. Every hospital and birth center in the United States that provides maternity service is asked to identify the person most knowledgeable about the facility's maternity care practices to receive the MPINK survey. Respondents either complete either a paper or a web-based version of the questionnaire, and they may obtain input from other knowledgeable staff. If you see, that's our 2011 MPINK survey that's up there. The CDC calculates scores for every facility and state to indicate their performance on the MPINK survey. Sub-scores are further categorized into maternity care practice domains, such as labor and delivery care, postpartum feeding of breastfed infants, breastfeeding assistance, postpartum contact between mother and infant, facility discharge care, staff training, and structural and organizational aspects of care delivery. So we have 44 birthing facilities in Mississippi. In 2011, we only had approximately 20 facilities participate, but for the 2013, we actually had about 35 hospitals participate in that survey. So what we want to do is to identify those hospitals and birthing centers that wanted to enhance support and staff members and policies and provide for breastfeeding-friendly choices.
Okay, I'm just showing a couple of the pictures of the Mississippi MPINK. Then, okay, go ahead, Tiffany.
So right here in this slide, it just shows the 10 steps to successful breastfeeding, and they include having a written breastfeeding policy that is routinely communicated to all healthcare staff, then also training all the healthcare staff in the skills necessary to implement this policy, then inform all pregnant women about the benefits and the management of breastfeeding, help mothers initiate breastfeeding within 1 hour of birth, show mothers how to breastfeed and how to maintain lactation even if they are separated from their infants, give infants no food or drink other than breast milk unless medically indicated, practice rooming in to allow mothers and infants to remain together for 24 hours a day, encourage breastfeeding on demand, not providing any pacifiers or artificial nipples to breastfeeding infants, and then foster the establishment of breastfeeding support groups and refer mothers to them.
Thank
that's
you.
That's our goal here,
okay.
and we're working collaboratively.
Well, it's really, really great to have you with us and behind us and working with us, and we really look forward to working with you on that partnership and working together because, you know, I think on the MPINK slide it showed that Mississippi is pretty much one of the lower level states in terms of the practices that are being met on MPINK. So we will all work together to improve that, and we really need everybody working together. So thank you very much, and thanks, Tiffany, for presenting that. That was great. So what are we going to try and do with this CHAMPS project? So, you know, I think the big overall goal for everybody is to try and increase exclusive breastfeeding rates in the South. And as I say, the areas of choice were through Kellogg, which is the funder, and they have areas in which they focus their interests on funding. And so that's one of the major justifications for why we're working with Mississippi. Our goal is to enroll 25 core hospitals in Mississippi, New Orleans, and Southern Texas, and we have not selected those hospitals. We haven't decided exactly what the distribution will be, but overall we're hoping to involve 25 hospitals directly. And our goal is to help at least 10 of those hospitals to actually become baby-friendly designated, and that would be to meet the 10 steps, which Tiffany just explained to you. We realize that not everyone is at that point yet. There are some hospitals where people just want to do a little work on certain areas or a lot of work on certain areas. They may not feel that they're ready to be designated yet, but overall we want to improve the maternal child health practices in those 25 hospitals. This is a picture of myself and Kim Bogg. We are the two people who are leading the initiative here. I'm based at the Breastfeeding Center in Boston Medical Center with a large group of support team. And then Kim is at Reaching Our Sisters Everywhere, and she has a team working with her as well. I'm just going to give you a 2-minute background on my history here at Boston Medical Center. We are the largest safety net hospital in New England. We have about 2,500 births a year, over the 15-bed NICU. We're affiliated with a teaching unit, the Boston University School of Medicine, with a lot of residency programs. We service a very low-income population, so and also a racially diverse population. 56% of our women who give birth are black, 25% Hispanic, and 11% white. Over half our population is on Medicaid, and in the days before everyone had required health insurance, 24% of our population did not have any health insurance, and 80% of our population is eligible for WIC, compared to a national average of around 50%. So you can see that in our hospital we serve a very low-income population. We also didn't do anything at all to do with breastfeeding until back in 1997, which seems like a long time ago now, but at the time it was still really not great to have not done anything breastfeeding at all by then. And when I started working there, my job was to see breastfeeding mothers, but no one actually knew who they were because we didn't actually record like anywhere easy to find whether people were even breastfeeding or not. Before I joined, one of my supervisors, Bobby Phillip, had done a survey of the pediatric inpatient, the pediatric outpatient clinic, who sees about half of the babies who are born in our hospital. And she surveyed 1,000 telephone calls that came into their service for follow-up and questions about the child, and there wasn't a single telephone call about breastfeeding, and that was because no one was breastfeeding. So I had a lot to overcome when I worked down there. We had very poor staff knowledge. Our policies were really obstructive. And we heard over and over again, our mothers don't want to breastfeed, which, of course, I did not buy. So we decided we were going to change our policies at Boston Medical Center. And I think our biggest overall change was our change in attitude. We acknowledged that we were the problem, not that the mothers were the problem, that we needed to change our systems and our policies that were keeping moms and babies apart and obstructing breastfeeding. We needed to educate all our staff about lactation, and we needed to reduce the influence of infant formula in the hospital. We did work on that. We became baby-friendly, and this was what came out as a result of that work. We had a huge increase in our breastfeeding rates, and remember, this is a very low-income population, underprivileged population. So we had a raise in breastfeeding initiation from 58% before we started the project to 87% when we became designated. And our initiation among U.S.-born African Americans, and we targeted that group to look at because that group in the United States has the lowest breastfeeding rate as a racial group. U.S.-born African American initiation went up from 34% to 74%. And our exclusive breastfeeding rate was just abominable. It was 6% before we started, and it went up to 34% after we did the project. So we really made a difference. We did look at our NICU rates as well. NICU is not a direct really participant in the Baby Friendly Initiative in a broad scale. They do have to do certain things just like everyone else in the hospital. They have to pay for their formula. They have to make sure that women have access to pumps and that kind of thing. And our initiation and exclusivity went up in the NICU dramatically as well. Our overall initiation went up from 35% of NICU mothers initiating back in 1995 to 74% after we had initiated the project. And again, among our U.S.-born African Americans, it went up from 35 to 64%. And one thing that was very interesting to us was that among our non-U.S.-born African American population with NICU babies, that rate jumped from 27% in 1995 to 81% in 1999. And traditionally, non-U.S. born African Americans actually breastfeed at very high rates. But I think in a NICU, they need lots of equipment and different kinds of support than they would need if they were in their own home. And it was very prohibitive to them when we didn't have a system that supported it. But once we supported them systemically, that group jumped up to a very high breastfeeding rate in the NICU. And of course, it impacted our duration as well, because if they're not starting, they're not continuing. So we went from 28% of babies getting any breast milk at 1995 to 66% in 1999. I give you these data because that's really what launched me onto my work with Baby Friendly. It really convinced me that this initiative would have a leveling effect across all different populations, that once you implement this, it will help women from all different levels of society, not regardless of race, ethnicity, income, education. That's what we found in our own hospital when we measured it. So I've been doing a lot of consulting since then. I worked with Laurie Winter, who's on the phone here, for a project that she did in New Jersey, looking at 10 hospitals and working on Baby Friendly for them. I'm currently working on a project with Oklahoma where we have a goal of engaging all 60 hospitals. We have about 20 of them on board right now. I worked for NICHQ's Best Fed Beginnings project, which Kim also worked on, and Laurie, which was 89 hospitals across the country. And I'm working with the Indian Health Service, and they have 13 hospitals. So we're really working broadly across the country. And I'm going to just let Kim speak up here and talk about the things that she does in her work that support baby friendly and breastfeeding.
Hello, everyone. Really happy to be here. I had the good fortune to be the NICU regional faculty for the southern states. So I was able to work with a couple of hospitals in Mississippi on their attempt to become baby friendly. I also have worked with WIC extensively throughout Mississippi and was actually able to do training in 10 WIC districts. So I really had the opportunity to meet a lot of people in the communities and to work with them. Rose, Reaching Our Sisters Everywhere, focus is to decrease inequities and breastfeeding disparities throughout the country. And so we've also done this for quite a few years in many states. And so I'm really excited about this initiative. I have family and friends in Mississippi. My daughter is actually at Mississippi College in graduate school now. So I spend a lot of time there already, and I'm really looking forward to visiting more of the churches. I happened to go to the mayor's church the last time I was there and had a great time. So more of the churches and other places in the community, and really looking forward to reaching out to all of you to help you, and also for you to help me to do whatever it is that you feel is needed to bring the community along. Thank you.
Thanks, Kim. And Kathy, would you like to speak up? Kathy is also helping us on the ground in Mississippi. She is, well, I'll let you introduce yourself, Kathy.
Well, thanks, Ann. And hello, everyone. I just want to welcome you to this wonderful initiative as we begin this truly important work, I think, of serving Mississippi families. I probably know and have met many of you and worked with many of you, but for those of you who have not had the privilege of meeting, I do work with a nonprofit organization, Every Mother, along with my colleague Kendall Cox. We provide lactation training and technical assistance across the country, primarily working with WIC agencies as well as providing training in hospitals. We have provided training in all 50 states, and we also do a lot of work with the government on national breastfeeding projects, including developing USDA's National Peer Counseling Program and curriculum for the agencies across the country. We developed the National Breastfeeding Training Program for WIC staff across the country through USDA, and have done a number of initiatives now with HHS Maternal Child Health Bureau and the Office on Women's Health that are particularly focused on supporting working moms with breastfeeding. So I guess in a nutshell, I could just say I'm passionate about breastfeeding, and it's really been the center of my career for over 20 years, beginning with the time that I served the Mississippi Department of Health, working right here in Mississippi. But I think, you know, with all the lovely national projects and initiatives and opportunities that I've had, for me personally, it's the greatest honor to have the opportunity to work right here in Mississippi with the families and hospitals and neighbors right here, people that I know and love. So I'm very excited about it. We have a lot to celebrate here in our state. We have a lot of initiatives that just need to be a little bit better linked together. We have caring people who want to make a difference in the lives of moms and babies, and I think that's a great formula for success. I do want to tell you all that I think you're really going to enjoy working with this amazing team that CHAMPS has assembled. They are some of the most wonderful experts in breastfeeding in the country, and it's just been a privilege already to have the opportunity to work with Ann and Kim and the amazing people, and I look forward to working with all of you.
Thank you. Thanks, Kathy. With that, I won't have everyone introduce themselves because I believe most of these people are on the call right now. But these are some of the people who are coming together with us to help us. Roger Edwards, who is an assistant professor at Northeastern and has done a great deal of work with the state of Massachusetts on one of the CDC grants. Jeremy McKinley, who is with Health Connect One and works with community doulas and other community health workers and has a lot of presence there in the South. Emily Taylor, who is a QI expert and has worked with the New York area, different hospitals there, making them baby-friendly, has a great deal of experience in QI and in working directly with hospitals. And Laurie Feldman-Winter, who is at Cooper University in New Jersey, but also is is the chair of the AAP section on breastfeeding, a pediatrician, and very well connected with physicians, and was also working on the Breastfed Beginners project. In my own hospital, we have my boss, who is a community pediatrician, Mike Silverstein, who is going to be helping us, especially with some of the outcome for assessments and determining if we're able to be making a difference in the community. And then Renee, who is going to speak up at the end of the webinar, and she is also a pediatrician at BU, Boston Medical Center, and she's going to be helping work with pediatricians and community-based assessment as well. Just to introduce my team, all of those who are getting the webinar together frantically at the beginning and have done a massive amount of work behind the scenes and will continue to do so. Our project manager, Laura Burnham, and Apexa Patel, who is our project coordinator. And Apexa has started to put together our website for CHAMPS, which you will have a link to at the end of this project. We're just getting it going, but we have some great support in the office as well. And then Doug Rockwell, who is too modest to put his photo on here, but he is our administrator and our financial director in our division, and he is also behind this project, making sure that all the finances are in order and that all our subcontractors get paid. The hospital goals. So what are we actually going to hope to do in this project, so sort of get down to the meat of it? We're going to, as I said, work with 25 hospitals, and we hope you're all clamoring to sign up. And what can we do for you? So as Tiffany presented at the beginning, there are 10 steps to successful breastfeeding, and those are the core. Meeting those steps is the core of Baby Friendly. So we want to look at those steps and work with hospitals on at least some of the steps, if not all of the steps, to help you implement some of those as best practices. And among The team that I just mentioned, we have huge experience in working with hospitals in all different parts of the country to try and figure out with them what's the best way that they can approach doing these changes, because we all know that these are the recommended standards. That's what the WHO recommends, it's what the CDC recommends, it's what the AAP recommends. All the organizations that we work with recommend that the 10 steps are used in maternity care. So that's what we're doing as an overall goal. Some of the real specifics that we can help you with, you know, I worked on the Best Their Beginnings project at NICHQ, and I think one of the things that we learned an awful lot from that project, and you know, good for them, because they really tackled a huge field, and it was an uncharted territory before. We were working with 90 hospitals. We really didn't know what was going to come out of the project. But one thing I think we all may acknowledge is that we did try and collect an awful lot of data, and some of that may have been onerous to the hospitals. So there are 3 areas that I really want to help the hospitals measure as we go through this, and one is the breastfeeding rates. So as most of you know, the Joint Commission requires that for hospitals of a certain size, you actually do collect data for any and exclusive breastfeeding. And my experience as I've gone around with different hospitals that I work with is that actually people are not very good even at doing that. The Joint Commission has had a few different variations on the theme of how to do this. So we have spoken to them, and they have agreed that when we get this project, they will help, when we get it going, they will help us to teach the hospitals how to collect that data properly. And then we will ask you to report that data so that we know that, you know, think where you're at, that you know where you're at baseline. And we will do something very similar for skin to skin and rooming in. Those are not part of the Joint Commission requirements, but they are 2 of the most important steps, and things that they're not very well documented or tracked. So those are the areas that I would like to focus on particularly, especially in terms of tracking information. So how are we planning to do this? Our goal is to connect with you, interested hospitals out there, and assess the strengths that the hospitals already have and the areas of need. And then, and I cannot overemphasize this enough, our goal at the same level as connecting with the hospitals is to connect with the communities. You know, it goes both ways, this initiative. I think one of the practical problems that a lot of hospitals have, for example, is that when they have people come in from prenatal clinics that are not associated with the hospital has very little control over the prenatal setting and has not been able to reach out and make change in that setting, so people are not coming in prepared. By the same token, we all know that very, very often there's a lot of will, desire, and strength in the community wanting to breastfeed. And I can honestly say that sometimes peer counselors I know more than doctors about breastfeeding. So it goes both ways, and the communities have a lot of needs and demands, frankly, for the hospital, that the hospitals need to be doing better. So we want to unite those 2 areas and put them together and have the communities and the hospitals really work together to do this. And then Kim is going to talk a little bit about some of the more altruistic reasons as to why this is really important for hospitals and communities, of course, to embrace.
I guess the next slide is.
Actually, I think, Kim, you're looking for...
we want to be sure to, as she said, include from the beginning, because we did learn a lot with the Best Fed initiative, and what the majority of the folks said towards the end is that they know for a fact that things would have been different if they started with the community, because after they did all the wonderful things in the hospital and things started to change, and then, you know, those things had changed for the community, it became a little of a problem when the community sort of was brought in last. So some of the things that we plan to look at and with you all is to actually develop some other culturally competent community support entities. A couple of the ones that we've looked at throughout the country, there are several different ones. We've looked at some that actually allow peer counselors and community groups to come in as volunteers, especially WIC peer counselors, and we have noticed that when in those communities where that happens and they have that great connection between the community and the hospitals, and they actually are able to come in as volunteers, breastfeeding rates, shot up a lot of times, like overnight. We've seen, like, in 3 months, a difference from 26% breastfeeding initiation to, like, 80% breastfeeding initiation in 3 months because of the community partners that were coming in and assisting, just talking to moms, not touching anybody, just helping them and talking to them and actually, doing that counseling and connection. So those are some things that, we'd like to talk to you all about and see if there are some ways we can institute some culturally competent sort of community support. We want to also make sure that we include WIC. A lot of the places that we travel throughout this country with the Best Ed Initiative, a lot of times folks will say that, WIC is going to be a partner. But then when we talk to WIC in the community, they're not part of the team, which they really need to be. And they didn't even know, that they were being sort of referred to in the step, especially in step 10. So we need to make sure that from the beginning we can bring WIC in. A lot of the hospitals that we were working with had, a 50 to 70% Medicaid delivery. And so it would be really nice to be able to also include those WIC from the beginning. And then outreach again to the churches, to non-traditional partners such as sororities and, the colleges, just the Masters of Public Health programs. I had a son recently who actually took a women's studies class. He was the only guy in the class, and there was nothing about breastfeeding in this class of college-age women, and so he did his report on it, and now the instructor has incorporated that into the curriculum. So we need to use every avenue we can with the colleges, with the sororities, with the churches, with the recreation centers. We want to include the partners. We have to include the men. We have to definitely include fathers and grandmothers and aunties. The Surgeon General's call to action states that the best programs to actually make change are action-oriented programs. So what you see on the screen right now are several groups that we just trained to a couple of days and give them some evidence-based information on breastfeeding and then kind of turn them loose in their communities. And we've seen, things just get so much better in those communities, breastfeeding looking more normal. And these ladies are just working with their sisters and their neighbors and their friends and, very passionate and enthusiastic. And, they know when to refer back to the experts also. So those are some things we want to do. We want to have community transformers all over, just making and helping breastfeeding to become normal.
Thank you, Kim. We kind of put your stuff into one place there. That's great. Thank you. So some of the practical help that we can offer to places is, I think, based on the group that we have put together here. We have a lot of pragmatic knowledge, and like Kim said about action-based programs, we really have worked with communities, worked with hospitals, and learned what we need to do and learn what works and learn what doesn't work. We will do webinars and phone conferences, and one of the things that we want to talk about as we go forward and we work with the hospitals, we actually have had a huge response from New Orleans, and we did have a lot of people interested from Mississippi. We do want to make sure that people are included, so even if we fill up our quota of hospitals, we would work with all the departments of health and the different groups to make sure that the webinars were available to a wide group of people. It wouldn't just be those 25 hospitals, but the ones that the 25 hospitals will have more of a focus, but we will make things like this available to others. We can do trainings. Kim can do trainings in person. We also have money in the budget for online training for nursing from the hospitals involved. So if you sign up and you need to train 10 nurses, we can contribute towards the actual cost of the online trainings There are a lot of trainings that will help with the Step 2 requirement for Baby Friendly, which is that your nurses have to have a 15-hour course, and that is available online from various different settings, and that is something that we can actually pay for. We cannot pay for the nurses' time to take the course, but we can pay for a number of slots in trainings for people for the hospitals. We also have QI guidance. We will be able to work on, help you with how to do PDSAs. That's the Plan, Do, Study, Act, or Test of Change. Type try it one time setting. We've had a lot of experience with that. We've taken a lot of knowledge of that with us. We've tried that in a lot of places. We know what works and how that works. And then we have Laurie on the phone, and we have connections, Dr. Collier. We have many other doctors around who are going to help us work with physicians, because we do know that physicians can be great leaders and they can also be a barrier. So we will help that. We have a lot of experience with that. We will also be able to help with policy and guidance and charting help. These are areas that we've got a lot of experience in between us all. We will definitely do site visits. You know, in terms of the selection process, we are actually meeting the group of us who you saw in the pictures. We're all meeting in the beginning of October to hone down some of these. But I feel that one of the most important things that we have learned is that we really need to talk to people and figure out the level of commitment from the hospital. So we will be doing site visits and we will be able to come to your hospital between us and help you and assess where you're at and where you would like to be later. We will be able to do outreach and education to clinics that we are working with, both prenatal and WIC, postpartum. You will have access through us to the U.S. Breastfeeding Committee and to Health Connect One, who are some of the Kellogg field builders. And what do we expect from the hospitals? Because it's not all one way, and it was Kathy that asked me to put this in, and thank you, Kathy, because definitely it's not all one way. And some of the things we have learned, I feel it's very, very important for the hospitals to have a committed team with clear leadership of the team and buy-in from the hospitals. Some of the projects I've worked on, it seems to me, in retrospect, that maybe lactation shoved this proposal in and got the hospital on board, and the hospital didn't really know what they were doing, and then we get there and it's really not a system-wide effort or buy-in. You do need some support from your senior leadership. Your main leader does not need to be a senior leader, but you need a group of people. We have had experience in hospitals where just nursing has been the real driving force, and they have made it happen. You need to get your doctors in at the end there at least, but we have seen some, you know, but you need to have a group of people. It can't just be one person. It needs to be a group of people, and they have to have a reasonable amount of clout. You need to be able to assess yourselves honestly and know where you're at. We will ask you to host us as a site visit team, and that you will attend meetings in the area, which we will put on for you. We want you to participate in webinars and calls like this one, and we want you to do stuff, because we have some hospitals that have been on multiple webinars and calls with us, and they've heard this stuff, but they haven't listened to it. And 2-3 years on being part of a project, some of these hospitals still asking us questions that we've presented to them over and over, and we've been there available. So you actually have to act on what we do. That's the commitment that we hope you will make with us. We are aware that you have time constraints, that this is not going to be the only project that you're doing, that it's something that you have to fit in amongst your daily routine, that very few of you will be lucky enough to have someone dedicated just to this kind of a project. So we value your time, and we will be consistent. We will work out with you what we want, and we're not going to change the rules halfway there. As I said before, we'll offer you tried and tested strategies for success. And we will tell you if we think that things are not going in the right direction. We're very open and honest here, and we too will do things for you and listen to you. And we did do the community things. Is Renee on the phone?
Yes, I'm here. Can you hear me?
Hey, Renee. So we're just actually going to close with Renee. Renee is one of our partners here at Boston Medical Center, and she's just going to give a little bit of a few minutes overview of how we've done some of these academic community partnerships in the past, and then we'll open up the webinar for questions. So go ahead, Renee.
Thank you all so much. I'm so excited and honored to be a part of this project. And as has already been shared by Anne and by Kim on the call, this work is challenging. Having an authentic partnership with communities, hospitals, and clinics is very challenging. And one thing we've learned through this work is that
the step of building trust cannot be skipped or fast-forwarded, and that one strategy that we've used that's been really successful is creating a sense of a learning system where we are all learning together, and that community residents and members have just as much as to add and to share to that learning system as experts in the field have to add and share, as systems experts and administrators have to add and share, nurses, doctors, and special groups. If we could advance. So as we think about the collaborative learning system as being the real home where we are all in a learning process and we're all sharing and offering things, you know, one of the things that CHAMPS is really in a wonderful position to host and to offer is a variety of tools and resources that can support this collaborative process, really help to develop community champions as well as hospital and clinical leadership, and really have the opportunity for the quality improvement process to be a shared process, not one just owned by evaluators, but one that's really owned by everyone who is very motivated and excited in seeing the dot move and seeing further uptake of these efforts. We're also really thinking very deep, in a very deep way about how community supports for breastfeeding may vary and be flavored by the region that we're working in and all of the expertise, culture, and heritage that's there, as well as the community development in that region and community-based agencies. And then in terms of supports for the specific healthcare systems themselves, we want, of course, to share exciting evidence-based models across sites, but also really think about developing strong clinical champions and partnering between hospitals and clinical settings. Next slide, please. Really, as we think about this collaboration, we really think about it as a learning opportunity, and we think about problem-solving tools that will really support measurement and evaluation of these efforts so they can truly be improved. There's been so much work and effort that has gone into this from so many talented and dedicated people. If this was a simple problem, it would be solved, but we know that this is a much more complex process, and it's really going to take the first step of mutual trust building and listening, and then really thinking about resource sharing and capacity building, and thinking about it in an innovative, of course, way, pre-conception, post-conception, perinatal, and postpartum. Next slide, please. So we're trying to build all of these components, and we really want all of your energy, insights, and ideas to really think about what are the resources and tools that are needed, how can we make this participatory and community-based, and how do we form the right strategic alliances that really align mission, vision, and goals. Thank you. I'm really excited to get started.
Okay, great. Thank you. So we are going to open it up for questions. I am just going to put down here, we have some information here. We have created an email address specifically for this project, which you can see there at the top, and it's champsbreastfeed@gmail.com. So even those of you who are not seeing the pictures, champsbreastfeed@gmail.com hopefully is pretty easy to remember. You can also email Laura, who is our project manager, and her email address would be on the webinar invite that went out, and she can connect you. And Apexa may be someone that you need to contact later if you have other specific questions. My email's also on there. Those of us at Boston Medical are all at bmc.org. And then we have a brand new website. We just put this up. It's under development, but we have started to work on it, so we will have a place to house this. And knowing my very young and enthusiastic team, we will have a Facebook page before long as well. But as I say, the whole project only just began in August, so we've just got started with putting up some of these things. But we will hope to be able to share many of the tools and resources through the website, through the Facebook page, so that we can get things up there to share generally. So just to sort of conclude with the overall view, we are at this point looking to enroll hospitals. What we can offer those hospitals is our technical support, an assessment that we will do with you to figure out where you're at, what your goals are, what your strengths are, where your problems lie, and then with that all in mind, geographically linking you in with the communities and working with the communities. And some of that can come in the other way around. So if we have a community that comes to us and says, we are a WIC office and we're in Jackson and we think that this hospital is really not doing a good job, we need this hospital to help us and get on board, we have all this influence. Or if we have a big prenatal clinic that says we're serving this small hospital, you know, we're not just looking for big academic medical centers. We will work with any size hospital. We just need some commitment, time input, and a desire to change. And we will offer you a great deal of resources. And we hope that in return, what we can offer the moms and babies of Mississippi is increased exclusive breastfeeding and a greater level of comfort with breastfeeding and a greater level of support with breastfeeding. So with all that said, I'd like to just open it up and take any questions that people have. Hopefully all your mics are open. Hopefully you've typed into the chat your name and institution so that we can see who was on. So please go ahead and ask any questions if you have any. Don't be shy.
Okay.
I think people are trying to get this stuff together. Yes, go ahead.
Yes, this is Gidget King, and I'm one of the lactation specialists here at St. Dominic's in Jackson, Mississippi. And I was just wondering, this all sounds amazing and wonderful. I know our administration is going to want to know how much it's going to cost for us. So does anybody have any figures on that yet?
Okay, so it won't cost you anything to join this project, okay? This is all for free. The Kellogg Foundation is offering, you know, they are paying us to do this. So there's no cost to you to join this. Baby-friendly designation has a cost attached to it that that is all available on the Baby Friendly USA website, and you have to pay a certain amount each stage that you go through. You know, you can do a lot of work with us and not become baby-friendly designated. It's nice to have that goal if you want to become designated, but there is a cost involved with that, and then you have to pay for their assessors to come out and assess the site. And in fact, we can get you the links to that. But if you go to the Baby Friendly USA website, which we will be working alongside Baby Friendly USA, but we're not connected with them in any, you know, there's no financial or otherwise link with that, with Baby Friendly USA, but they have those costs spelled out. If I'm looking at the costs that are associated with this type of program, which are not directly payable to the organization that comes along and designates you, the main costs I would say for you would be staff training. And as I said, we can actually offer you some of the online training for free, but many places do have to pay their staff for time that is spent training. So that's a cost. And then some hospitals, you know, one of the things that is encouraged is that you pay for infant formula. So that might be another cost, although that is not anything like as expensive as people think. Does that answer your question? But being on this project won't cost you anything except your time to work on it.
Thank you so much. So
it sounds too good to be true, I know.
It does. And the only other thing that I was thinking that might cost would be the cost of going to regional meetings.
Yeah, we have some support built into the system for that, and we'll bring them to you. But yes, there might be some, depending on how many people you want to go. You know, if we have loads of places sign up and they want to bring loads of staff, I don't think we could cover everybody. But we do have some support built into the project for travel and bringing hospitals to the conferences. So it might not be completely free, but it would be subsidized by us.
Thank you again. And one more question, and then I'll let everybody else talk.
Okay.
What's the next step in the application process?
Okay. Well, those of you need to write to us and tell us you're interested is the bottom line. Anyone on the phone who has an interest, just write to us, because as I say, this is informational. We have not figured out yet exactly how we're going to assess the hospitals. We have very good reference frames for how we've done it in the past and what we're going to do. But right now, if you email champsbreastfeed@gmail.com, or if you don't like emailing that, it'll go to the same person, but you can email Laura Burnham, just with your contact information and saying at this point you're interested. You can also reach out to our partners if you know Kim or you know Kathy and your hospital's interested and you feel better chatting with them and telling them, and then they can contact, they will let us know. Right now we are definitely looking to compile a list of hospitals that are interested. And as I say, interested, not committed and not guaranteed yet from our side, who we want to take in. I think one thing we will want to do is to look for a geographic spread so that they're not all concentrated in one area. And, one of the things that Kellogg gave us as a mission is go to places where this hasn't been before. Go to places that didn't hear about the Best Fed Beginnings Project. So we're looking to specifically go to some of the poorer parts of the state where I know that there's a lot of poor parts of Mississippi, but some of the parts that really, when you think about Mississippi, you think that's the place that needs the help the most of all.
Okay, thank you so much.
Okay, other questions? Any of our partners want to share anything? The people that are on here that with us that haven't had a chance to speak up yet?
This is Dr. Collier. Can you hear me?
Yes, very well.
So I did want to share, we have so many folks on the phone that, the State Department of Health, along with many of our state hospitals, insurers, as well as March Dimes and other partners are working on establishing a perinatal quality collaborative for the state of Mississippi, which other states like Ohio, Tennessee, Massachusetts have, which really works on bringing partners together to promote evidence-based practices in maternal and infant health. And this is definitely right in line with that, and we would certainly want to consider that like a partner initiative. And we are holding our first kind of statewide meeting in November 21st, and I'll send an email out to the organizers that would certainly be happy to host a special session on CHAMPS for that. We do have meeting space available, and we actually do have some travel support for that meeting for hospitals coming from a bigger distance, so we're happy to collaborate on that. So I'll just let the organizers do that. But also, we definitely hear you in terms of like initiative overload, and there's lots of different, if it's the 39 weeks or if it's safe sleep initiatives. We know we ask a lot of hospitals, but we're going to do our best to help coordinate all these in as many ways as we can and try to get everybody, on the same page so that we're promoting, the same practices and trying to streamline all these different efforts to improve outcomes in our state. So I just kind of wanted to put that out there and, let you know you do have our support in terms of working with the other initiatives we're trying to get promoted. And one of those is specifically like breast milk in the NICU, but as you said, this goes way past neonatal intensive care units, so we do, collaborate as much as possible across the board.
Thank you. That's great. You have a milk bank there in Mississippi as well, right?
What's that?
You have a milk bank in Mississippi?
That's got a milk bank in Mississippi, so we are trying to work to enhance that and get that further off the ground, and so yep, that just opened. They've been working on it for many years, and I'm not sure if anyone's on the phone from the milk bank, but we do just open our first one.
Great. And I already got a response. Roger's been looking at our website, and he just sent me a link to a free CME 3-hour training for pediatricians. For physicians. You want to speak up, Roger? I can hear you trying to get in.
Sure. I just want to mention that it's great to hear that you're doing that, Charlene, because in Massachusetts, the Department of Public Health has had a great impact in helping support materials that are available for free for everyone, including training for physicians that accounts for the 3 hours required for baby friendly for the physicians, and then it also is helpful for the nurses. It's 3 hours for nurses as well. And we've had over 1,600 physicians and nurses do that CME in the first year alone, and of its availability. So that's great to hear that you're doing that, and it's been a big help to have that resource, and it's available to everyone on the phone and elsewhere as well.
But just for those of you who maybe we were talking over each other at the beginning, when you do baby friendly, your physicians are required to do a 3-hour training. The physicians being the people who work with moms and babies, the only people that really You absolutely have to train. I mean, you should train a lot more people, but the only people that baby-friendly require you to train, and we're talking nurses and doctors, is anyone who works with moms and babies through the time when mom comes in labor and when she goes home with her baby. Those people need to be really well trained. Those people need, if they're physicians, they need to have a 3-hour training. And what Roger is talking about, they've actually made available through Massachusetts to any clinicians. It's a CME 3-hour course, and we are just about to add it to the CHAMPS website because Roger just kindly sent us a link. So, and you don't, I mean, anyone can do that training. You don't have to be part of CHAMPS. You don't have to be going baby friendly. It's a 3-hour CME training for physicians about breastfeeding and baby friendly. So, thank you, Roger. Anyone else? Any other questions before we wrap up here? Can you unshare my screen, Laura, so I can just get back out of this? So thank you, everybody, for your participation. We are excited to have so many of you on the call. We have recorded the webinar so that we know that if you want the link or you want to send this to other people who weren't able to make the call, you can do that. We're having one on Thursday for New Orleans for any of you who might happen to cover more than one area. And we will have one later on for Southern Texas. So any last-minute questions before we wrap up? And thank you. I see many, many people on the phone here, so that's great that you're all on here. Any questions? I'm just looking at the chat because I don't have access to all this to see if anyone... Yep, I see Brittany said there's a milk bank open in Jackson. Yep, that's great, guys. You're ahead of that. You're ahead of the curve having a milk bank right there in Massachusetts. Okay. All right, well, thank you all of those many participants we have on the phone, and thank you for talking, and thank you for your interest. And please email myself, Laura, look at our website. Send us things that might be of interest to the website. We can put stuff up from the communities. Those of you who are not affiliated with a hospital but want your hospital to get involved, you send us an email. We'll see if we can get on the trails. Kim or Kathy, any last-minute thoughts before we close?
No, I just want to say again how excited I am about this whole initiative. And please reach out to me and let me know if you have any questions, comments, or concerns.
And this is Kathy. I just want to thank everybody who's been involved with this. This is a really exciting opportunity for Mississippi, and I'm just really energized about the opportunity to gather together and build on our strengths and work together. We've got work to do, so let's get started.
Thank you all, so many of you for participating, and we look forward to hearing you and hearing from you and coming down to see you and coming across to see you and getting this going. So thank you all, and do email us if you have any questions. Thank you very much. Okay, bye-bye.
Bye.